to read it on behalf of primary care, if Karen isn't on.
I don't see her,
Marianne,
Yeah.
I think we're en route to Onion.
Okay. So this safety story is reluctance to simplify. Primary care service had difficulty in meeting the new patient access goals. So rather than simplify the matter, primary care worked with the GPM and the primary care chief, along with other members of the primary care administrative team, performed a deep dive into the wait time calculations. And by doing so, they learned valuable information that will help meet these benchmarks. With the information they learned, they will be able to educate staff, take specific actions so that they can avoid scenarios that will lead to greater wait times. During their deep dive, they learned if a patient is scheduled for multiple appointments at the same time of the create date, all of those wait times, as long as they included a 323 PC stop code, will be included in the wait time calculations. Some patients are scheduled with clinical pharmacy or an RN visit along with their primary care visit, for example. More reason to encourage patients to accept sooner appointments. Consider not scheduling multiple appointments if necessary. Patients who were previously seen in clinic, including the 323 stop code, but not as the only stop code, will be considered new patients. For instance, if the patient were to simply be enrolled in ID primary care but are transitioning to general primary care, they'll be considered new patients. This is important for staff to understand that these patients are considered new and will affect patient wait times. For patients who no-show their new patient appointment, the clock does reset, with a new create date. Thus, very important for that appointment to be dispositioned correctly and promptly. New patients who are scheduled via consult will have the time from the consult to the time of the appointment also reported. So primary care is reevaluating the use of the administrative primary care consults. I think this is a good example of the team working together and looking at the root cause of the problem and looking at options to resolve it. So good work, primary care, GPM, and primary care nursing.
Yeah, thank you, Marianne. I think one of the largest pillars, or not largest, they're all the same size, is some improvement. And HRO and having these improvements and processes, I know it's challenging for staff when we have so many metrics, so many measures, so many things that we have to look at. But when a team comes together and approaches it from a perspective of how can we make improvements, I think we're seeing some great things. I can recall, and I know that you don't want to hear the stories, but I can recall when one director said to me, "Darlene, I want the medical center moved 2 feet to the left." Pulled the team together and we laughed about how you can't move a building. I mean, engineering will tell us that. You all know that. So we looked at it from a different perspective, and the different perspective was, instead of moving the building, we moved the sidewalk. And so so I think that the moral of that story is we have to be willing to look at all options, be willing to do the things that that a lot of people have a lot of different ideas, and it takes a team to make improvement. So whether it's just a small process improvement, whether it's a full-blown black belt type event that we're doing, these small improvements or large improvements will impact Albany's success. So extending appreciation and to primary care and to the GPM for attempting to make it better for our veterans, and they do. Anything else from anyone?